share with us and everything, but I think just with the hour, I think we've got some great speakers, so we really need to crack on. My name is Charlotte Pace, and I'm a research associate at IVAR, which is the Institute for Voluntary Action Research. And I'm here with colleagues today, Jessica Allen from the Institute of Health Equity, for Health Equity, and James Rowland from Brighton, a Commissioner from Brighton and Hove City Council. Part of the reason that I'm chairing this session here today is because of the, around social value in health, is because of my involvement in the National Health and Social Value Programme, which I don't know, some of you will be familiar. Felicity, you will be familiar from North Tyneside, you will be familiar from Milton Keynes, that has been running for the last 3 years. And this has been funded by the Department of Health to look at the implementation of the Public Services Social Value Act. And it's an action learning programme, so it's been a programme where we have worked alongside a particular area as facilitators, developing a partnership, cross-sector partnership, specifically with health and wellbeing boards, local authorities, clinical commissioning groups and the voluntary community and social enterprise sector. And it's good to see Milton Keynes from the first round. In fact, I will be coming to you. In year one, we worked with Calderdale, Holton, Milton Keynes and Salford. Some of you will have heard from Salford and Holton in other workshops today. Year two, we worked with Haringey, Leeds, North Tyneside and Reading. Hiya, come on in. And this year, the final year of this programme, we're working with Brighton and Hove, Lambeth, Oldham and Shropshire. If any of those areas resonate or ring a bell, or you think, oh, I wonder what they're doing, do come and see me afterwards and I can hopefully broker any contact. But we do have a practice development network as well, so there are ways of finding out more about that programme and what it's generated. And each area is developing a case study of its journey, or has developed a case study of its journey, and they are publicly available. So if you want to find out more, just come and let me have your contact details at the end as well. So, and all I've done really here, because I'm chairing this session, not leading it or speaking in it really, just pull out, from my experience, what some of the achievements have been around health and social value. And one thing to say, the programme, because it was funded by the Department of Health, focuses very much on the health issue, but it has gone wider than that, and a lot of areas have chosen, okay, we'll start looking at it in a health context, but what we'd like to do is broaden that out city-wide or county-wide. So it's not exclusive to health, but that has been the starting place, if you like. Some of the achievements have been around protocols, policies, and processes. There's several people in the room who have been working really hard on developing their social value policies. And in fact, a conversation earlier with Felicity from North Tyneside is about now we really have to get on and implement it. Now we have it through the Health and Wellbeing Board and endorsed and supported. Those are the next steps. The cross-sector partnerships that have been built around social value have been particularly pivotal. Something that's been mentioned in a number of workshops is about social value at the core of contracts, and that's been quite a big shift for some areas as well. And Health and Wellbeing Board Champions has been quite key. Those are a few of the themes from the programme, but it really has been an absolute pleasure to be involved in it and meet so many people doing all sorts of different things across the country in this area. So that's really the sort of context, or if you like, the sort of programme that we've been involved in and where my experience comes from in this. But I'm now going to hand over to other experts. And what I'm going to have to do is jump a few slides forward, because what we've decided is, I think, for an overview of the context, particularly from the Institute for Health Equity, is hear from Jessica Allen first and then move over to hearing from James. Both of our speakers will speak for approximately 10-15 minutes, and then we'll open that up for your questions. Does that sound about right? So forgive me now as I flick through a number of slides and get to the next place, and we're going to work in a little bit. But it gives you a taster, an exciting taster of what's to come. We're going to, that's my excuse anyway, for not having a better way to do it. So I'm handing over now to Jessica. Yes.
Where am I pointing?
The green one.
That way.
Anyway, I think.
Okay. Well, hello. So I work at the Institute for Health Equity, which is led by Michael Marmot. And since we published the Marmot Review, we've been working to embed recommendations around tackling health inequalities, and we've been working with local authorities. We've just started to work with the NHS, which I'll mention. We've been working nationally with PHE and the Department of Health. And we see the Social Value Act actually as quite an opportunity to tackle health inequalities in an area where there aren't that many opportunities and there aren't that many levers. We saw the legislation actually as quite promising in this area. And I'll just overview where we are with health inequalities, some of our analysis around the Social Value Act and the opportunities it could offer, and in some areas is offering to tackle health inequalities. And then there's some case studies, many of which you're working in those areas, or you'll have heard about, I'm sure, earlier today. So just as an overview, I hope some of you at least are familiar with this graph. It was the first graph in the Marmot Review. I'll just very quickly run over it. The bottom set of dots, that's life expectancy, healthy life expectancy, So this bottom set of dots represents how long you can expect to live in good health. And you can see a systematic variation on what we call the health gradient. The most deprived neighbourhoods are down here on the left, and the least deprived, the wealthiest, are on the right. And the top set of dots, that's life expectancy. So you can see two things from this. Firstly, that there's a systematic relationship between deprivation and both healthy life expectancy and life expectancy. And all of us are on this somewhere. I don't know if we're at the very top, but we'll be somewhere on this distribution, living lives that are less healthy and less long than the very wealthiest in society. The second point to make is that down in the most deprived neighbourhoods, you see that healthy life expectancy is around 50. This is for men. Slightly higher rates for women, so they live a bit longer life expectancy, but they live longer in ill health. So down at the bottom, in the most deprived areas, you see that there's a bigger gap between healthy life expectancy and life expectancy than there is at the top. So if you're living in poorer neighbourhoods, you live less long, or you're likely to live less long, and you're very likely to spend much more of your shorter life in ill health. And these are systematic relationships, and the pale green dots, the smudgy dots at the bottom of the edge of that was the previous time period, 1999 to 2003. You can see where we are with the latest set of figures up till 2013 with the more defined dots. So everything's got a bit better, but those inequalities are still there. They're very persistent and they haven't shifted. In fact, in some cases, they've got a little worse. So that's where we are. So we see health inequalities really is affecting the whole population. It's not just those at the very, very bottom end, the most excluded, the homeless. And there's a lot of action, well, there's some action around trying to improve outcomes for those groups, but very often the rest of the population, that those inequalities are overlooked. So we talk about the need to have universal approaches, but those which are proportionate to the scale of the problem. So just very briefly to summarise, health inequalities we think is the greatest inequality of all, and it's very often not seen as that, but if you talk about people's priorities, health, how long they live is of course a huge societal priority, if not the greatest. And these systematic relationships between health and deprivation and a variety of indicators aren't a result of the healthcare system. So in England we still have the most equitable healthcare system. It's not perfect, but it's pretty equitable, and it's about as good as it gets globally still. So we know that these health outcomes are driven largely by the social, economic, education, political, cultural contexts in which we all live, and that we've been producing abundant evidence about the relationships between these factors and health outcomes for a number of years, as have other people. So it's about the conditions in which we all born, grow, live, work and age. And we can improve the NHS and make it more equitable, but we're not going to shift those really systematic health inequalities through the NHS. It's also very expensive. So we're always asked, always, and increasingly, with louder voices asked to show the cost implications of what we're talking about, how much it costs to rectify. And so we talked about the cost of doing nothing. So these health inequalities are not only hugely costly to individuals, obviously, in terms of health and their length of life, and to their families and communities, but also to the nation as a whole in economic terms. So we're looking at cost to the NHS. The economists worked out that was around 5 billion. I think that's a very, very conservative estimate. I think they're far higher costs. All this unnecessary ill health that we see in the demand on the healthcare system as a result of this burden of ill health, at least around 5 billion, and I think considerably more. We see loss in tax revenue, higher welfare payments as a result of this ill health every year, 20 to 32 billion, probably gone up. These were figures we did for the Marmot review. Productivity losses, 30 to 30 odd billion. So looking every year, we talk about 70 billion costs. So if you don't do anything, that's a loss of around 70 billion before you've even started, really, and that's the way we frame it. So this is a report that we did as part of our efforts to have the action around health inequalities taken up and implemented, and we looked at the possibilities of using the provisions of the Social Value Act to tackle inequalities. It was commissioned by Public Health England. It's available on our website, their website, and it talks about how the Social Value Act can be used to foster action on these wider social determinants that I've talked about, which are driving these health inequalities. So, of course, you know the provisions of the Social Value Act and the considerations that are required to consider economic, environmental and social well-being of local areas through procurement. Those are the social determinants of health. So improvements in those areas, in local areas, will translate later, probably, some immediately, but others later, into better health and reductions in health inequalities. So through that, we see huge potential to improve local food procurement, to improve local conditions and drive better health. And of course, you know that it applies to local authorities and to NHS organisations, of course. I will also say it applies to government departments, to NHS England, and I think that uptake nationally, in the national government departments and so on, has been slow and has been driven locally, and I think we really need to push on government departments who are spending all these umpteen billion without knowing where the impact, how the impact is. So there's a huge opportunity there as well. So there's a strong case for implementing social value approaches to reduce health inequalities. And this, if we need to make the case, other than just it's going to lead to improvements in health inequalities, and we increasingly find we are asked to make the financial case, it should reduce demand on NHS and other services, savings to the public purse. But the NHS has been relatively slow at a national level to take up the provisions. Of course, there are very noticeable exceptions locally, and we're going to hear from some, and many of you represented in the room, but it hasn't been at sufficient scale or system, despite the fact this is a legal obligation, as you know. And the other thing that's been drawn to our attention repeatedly is the importance of helping public authorities to prioritise services when decommissioning, when they are able to consider the wider health impacts of what they're decommissioning, which is, of course, is what many local authorities and NHS organisations are having to deal with. So that's another important way of assessing impact, is to look at the broader social value. I've made this point about government departments. I'll probably make it several times. It does bother me that local areas are being asked to drive forward social value approaches, and it's not such a priority nationally, I don't think. But the NHS, there's opportunity here, significant opportunity through the 5-year forward view, which of course has a focus on the NHS's role in improving health, because they've quite rightly clocked that prevention is better and cheaper than cure, and that the NHS really needs to focus far more on preventing ill health and reducing these inequalities in health. And I think at national strategic level there really is momentum behind that at the moment, so we have to try and make the most of it. And there's opportunities here to use the Social Value Act to achieve just that. So we're working with some of the vanguard sites, and we're trying to push forward some of the social value commissioning with the vanguards, and this is just beginning, but it's an opportunity we'll be drawing on examples where this has been happening in very encouraging ways. Just to make the point about how improving the economic, social, environmental areas through commissioning can impact on... Oh, it's one of these, sorry. There, no, not gone too far. There we go. These are some of the ways in which we could see direct and clear health benefits through economic and social environmental procurement spend, reducing local employment, increasing living wages. There's huge amounts of evidence about how these improve health in quite short term, actually. Health, increasing standard of living and opportunities, improving education. These are all health measures, all of them, very clearly. And to make that case and to have these areas aligned would be doubly strong case, I think. Community engagement, reducing social isolation, absolutely critical. We know how much ill health social isolation drives. It's enormous. It's almost as much as smoking, apparently. So it's not as well talked about in public health terms, but it's driving huge amounts of ill health. Tackling abuse, domestic violence, crime more broadly, green spaces and activities, improving housing quality. So all these areas which local authorities do routinely, these are health improving measures. So paying a living wage, of course, that's a clear one. That was one of the recommendations from the Marmot review, and I know that does feature in a lot of the social value procurement that's been implemented. And we can make the case that this is a very clear health measure as well. Trying to think about how we could get the right measures in place in order to measure impacts on health through procurement, through the spend, through these measures that we've just seen as well. That's critical. When we were talking to local areas about some of the barriers to implementing social value procurement, measurement came up time and time again. And so we did some work thinking about how you could build health into that and well-being and mental health into those sort of outcome measures as well. And the importance of recognising inequalities, because we can improve averages but not improve those inequalities. We just pull them up, or they're even steeper and you've got the same average. So we need to actually think about distributions, and that's quite hard to do through procurement, but it's absolutely essential, because we're not going to achieve much just by doing that, and the inequalities won't be tackled. Nationally, of course, the NHS spends 110 plus billion, goes up all the time.
I think your slides are mismatched with what I think it's that clicker thing. So if
Right, sorry.
Sorry.
This is the problem, I'm not being able to see them.
Yeah.
Where have I got to?
Yeah, I think it's the next one.
Yeah, 110 plus billion annual spend. The King's Fund did a very good report a year or so ago, and there was no overview of how that money gets spent. I mean, it was spent on clinical services, obviously, but in terms of alleviating poverty, which is driving so much ill health, in terms of the social, economic, environmental impact, nothing much, if at all, is known. And locally, a tiny bit more is known, but not much. And certainly NHS England's direct commissioning doesn't really consider social value at all. So I think, again, opportunities there. And I've mentioned the 5-year forward view. That is an important strategy for NHS England, and it does tie it. We can make the case it ties in with all of this. So again, a coherent position on using that procurement to improve health. We think about some of the ways in which this can be done. I'll just mention Blackburn and Darwin, which was one of the areas we first encountered, which really alerted us to some of the possibilities. You may know about this, but the public health director at the time decided to overview what he was spending his budget on, and of course his budget was allocated, weighted for deprivation, because it's one of the most deprived areas in the country, and he saw that a lot of his spend on non-clinical services was flooding out of the local area. It wasn't being spent locally, it wasn't helping to support local employment. It was actually, a lot of it was coming down to the south, and they were getting their staplers and paper and so on from Southampton, because that was the lowest cost, and it wasn't considering the environmental impact, firstly, of the transport of all of that or the impact on the local economy. So he pulled all the spend that he could back and made the case that although it wasn't necessarily the lowest cost, it was going to have the greatest impact and ultimately reduce costs, and that was accepted, and that's what he did with his public health spend. The living wage, we've talked about local employment and reducing poverty. Halton, I think, been talking today, but of course they've got a very holistic strategy to social value, which is, am I messing about with these again? Yeah. Tell I didn't draft these slides, I'm sorry, I shouldn't. So that's Halton, Liverpool as well, really driving forward on some of this. They've built it as a cross strategy, and when we talk to local areas, and this is all in the report, we identified key factors for success. Central among those was having social values spread throughout the whole strategic direction of the organisation. Very strong leadership was obviously critical in taking the whole organisation with it. So a number of kind of factors around leadership and organisational development around social value, which seem to be, from what we heard, the most important things in driving through social value approaches, and likewise the barriers were resistance to it, or poor leadership, or lack of accountability, or in some cases procurement teams not being on board, or thinking that they had to consider lowest cost because that was the requirements on them to do that, but of course that's shifted. So what Liverpool did was take this very cross-organisational approach and really build from that. Salford, again, I think you heard from earlier in the day as well, but they've really built that into the contracts. We've got lots of other case studies and good examples as well. As I say, most of these are local. They're not national or government departments where our good case studies come from. So just to make that point again. So as we work with the areas that we work with and support, we really are prioritising social value approaches and encouraging areas to look at this. We work with some local authorities and, as I've mentioned, with NHS organisations. And there's a bit of a sort of, in some NHS organisations, there's we can't really do that, it's got to be lowest cost. We're looking at the clinical outcomes, but we're making the case that you can do both, and that's really important. So we'll push on that and try and link those commissioning teams and so on in with other areas where they've been doing it successfully, because obviously that's very, very helpful. So we say that social value is an opportunity to improve health and reduce inequalities in those social and economic and environmental factors which drive health. This is locally and nationally. It's an opportunity to work the economic power of public procurement and an opportunity to align with other obligations and priorities. So if you're pushing on local employment, it's not just about building local employment, it's also about improving health. So you can really, really strengthen the case by adding health in there and aligning these agendas and getting sort of double impacts from the social value approaches. And of course it's a legal obligation, and there should be some strong accountability mechanisms to ensure that it's really taken up. Okay, I'll stop there. Quick run through. Thank you. And hand over to Jim.
Okay, so giving us a really good overview there. What I'm going to do now, you can flip back if you want. Yeah, you do it rather than me.
Quick memory for everyone.
Any questions that you'd like to pose to Jessica about any of that she's spoken to in that small amount of time? Does that resonate with you? Is that your experience? There's some nodding happening in the room. What would people like to hear more about? I mean, we talk about a lot about local examples driving this, and in the report there are local examples.
Yeah.
Since that report, there are more local examples. So it feels like one of the things around that is influence of where it works and building evidence. And
It's critical, I think, and it does really shift people's thinking if they see other places, of course, that are doing it. So we would like more examples, because as I said, we started this work with the NHS, and if people are able to send us case studies and so on, that's very, very, very helpful.
yes, do you want to? If you just say where you're from.
Yeah, I'm from Surrey County Council procurement team working in public health. Something that we're finding increasingly challenging, particularly with both the cutting budget in public health and the local authority financial assessment, is that when it comes to dealing with members, although we can argue that X amount of spend on a spot smoking service has a saving to the public's purse, in the bottom line is that it doesn't have a saving for local authorities. I think having routes by which we can generate social value opportunities through these contracts to then contribute to the local community is a nice way of arguing against that. But are there any examples that spring to mind, or case studies, or any comment that you have on ways in which we can do that? Because we're sort of in our infancy in effectively being able to measure and demonstrate the financial benefit of a social value strategy.
No, I mean, off the top of my head, no, we haven't got that kind of evidence, and we hear that this repeatedly, this is what's needed. And we can make the case generally, and we'd like to see local areas, you know, doing the work. And I know it's very difficult, and so we're kind of in a slight evidence gap, I think. I mean, we do have lots of evidence about the impact on local services, but we haven't costed it. So we can show local service impact.
I think there might be a couple. I'm just wondering about Dudley, and I'm just wondering, because Dudley might be quite near to being able to quantify the difference it's made, having a social value, social impact strategy running through there. I'm not really asking you for an answer, but I'm just thinking that Dudley was, it's sort of, if you like, integrated sort of strategy around the voluntary and community sector in the CCG and the council quite early on, and they are starting to see some of the results of that. You've drawn up a case study. There was a case study that started to draw some of that out, but I think it's probably just now, in answer to your question from Surrey, that information is starting to develop. So I think we might be about to see some of that. Certainly when we're working with local areas around developing social value frameworks, policies, that kind of thing, we're suggesting or heavily influencing people to integrate an evidence, collecting that evidence so it can be demonstrated, because obviously people need to make cases like yours. So I think there are a couple of early implementers, if you like, where it might be useful. Dudley would probably be one of them. I think there are a couple more. The Social Value Hub is a really good place for finding out about that. But it'd be quite useful to have a separate conversation about the programme and what people are doing in that programme as well. Thank you. Anything else people want to ask Jessica? A lot of areas have used some of the things that you've outlined in your presentation to make a case for a social value strategy, for a framework and things, and Holton is an example of that. You've done that as well, haven't you, in North Tyneside?
Yeah, we've done it in Milton Keynes as well.
Oh, you've done it in Milton Keynes as well, so that you've got that sort of evidence base around the social determinants in health as well. The report is very detailed, really, on some of the on what works and what doesn't, as far as you were able to at the time, and we've already got more that we can sort of build on that. So we need to have a conversation with you about the new stuff coming through.
Yeah, great.
Because it's ongoing. Because the brilliant thing about having a programme funded, apart from the fact that it's now ending by the Department of Health, is that it was a 3-year programme. So it was a rolling programme. The 12 areas came on board. So there was great opportunity for learning, and it hasn't finished. And that learning will be disseminated outside those areas. And I don't know if you had any thoughts around, because you got really good political buy-in in North Tyneside.
We did, yeah.
Picking on you, but
No, that's fine. I mean, a lot of our social value work was led by the Health and Wellbeing Board, and the chair of the Health and Wellbeing Board is the cabinet member who also is cabinet lead around public health. And actually, as a result of her intervention, we've now built into all procurements 10 to 20% of the procurement value will be based on social value, and it was the cabinet member that pushed for that because she recognised sort of the benefit to the kind of the local pound, and that was really a lot of her focus in terms of wanting North Tyneside, wanting to kind of focus in making sure that the kind of overall value was kept within North Tyneside. So we haven't, in terms of being able to evaluate it, being able to necessarily sort of evidence base it, but the fact that you're talking about actually trying to look at health, well-being, kind of local value within North Tyneside, that really is swung it. So we, as a result of that, we've had fantastic support from our cabinet.
So that's a good example, Jessica, we probably need to share with you more about. Sue.
I would love to be able to say the same.
Yes, this is a different story.
Yeah, when we did ours, we did get buy-in from the Health and Wellbeing Board, and it was adopted by the Health and Wellbeing Board unfortunately in Milton Keynes we have a system where a certain proportion of local councillors have to be elected each year. So we are constantly changing leadership all the time. And when we got it adopted, it was actually the Conservatives who were in charge of the council who adopted it. We now have Labour who sort of stuck it in a drawer somewhere. The problem we've got now is that health and wellbeing, and we're still working with the Joint Commissioner in social care and health, and we've sort of got an executive type committee, and we're meeting with blue lights now to cross over strategies. We've still got the rest of the council that actually doesn't really understand social value, although it says it does. It's just tweeted it does. Basically, that they're working in their little silos. You know, this is our money, and we're going to keep it. So a recent community buildings contract that came out started with social value as 10%. It was then called in and went to 5%, and now it's 2%. And the same value is put on a drinks machine in the foyer to generate income. So we're slightly going backwards.
So the picture is varied.
The core is still pushing forward. We will get there in the end.
Perseverance,
Yes.
yeah. And that was, you know, wasn't just lucky because she was an incredibly passionate committee. That chair of your health came to every single health and social value session.
Yeah.
So, you know, that getting that political buy-in at the outset was really, really helpful. But it fitted with her complete way of doing things, which I think was really good. I don't know, has anyone got any other questions for Jessica at this stage? Around the research that they've done at the Institute of Health Equity.
Can I just add one thing which may be helpful, which is that there was some health equity indicators, NHS equity indicators likely to be published very shortly, and they will show things like hospital utilisation, GP attendees and so on by small area deprivation. And they're quite clear, showing that in more deprived areas there's greater use of the NHS. So if that will help strengthen the case around costs, I know it's not necessarily, it's not necessarily from the same organisation that the savings will be made, but it can, you can use those kind of indicators at local level to show it's driving a lot of demand in the NHS.
That's useful. Sorry, Mark, and then...
I was just coming back to that. The work we've been doing in Dudley, we've been able to map things down to GP and down to the actual GP who's doing the referral for a social prescribing project where they're kind of moving people away from inappropriate presenting health into social. So we're able to track the entire journey of the client through that. And that's already showing, for example, we're able to map the social issues for the person, the medical issues, and then map it actually against GP locality. But what we're also interested in looking at is the actual GP themselves that's doing the referral. Because there seems to be some evidence to show the earlier, more recently qualified, more likely to be looking at social prescribing as a brief. So some interesting stuff there that I think feeds into sort of this. And I was saying to Charlotte earlier, the early evidence is that this is saving around about £3,000 a person. So that's not official, but it's kind of around that.
And that's where I think some of the evidence that could be supportive is about to come from. But we can talk about that. And also, sorry, can I just, before we move on to Jo, so if we could just have this as the last one and then pick up anything else at the end, that would be great.
Alison Reed, Executive from Dental Services. It's interesting listening, I mean, we're very strongly aligned about health inequalities, particularly in tooth decay. I understand and can hear exactly that it's pretty easy to do things at a local level, but the problem is if there isn't a little bit more joined up thinking at the commissioning level, nationally, we've got real problems, because I think being able to demonstrate that you save money in another part of the system isn't in your business or isn't in that commissioning budget is extremely difficult, and it is not cutting any ice with anybody. But then I'm just interested in you saying about these equity measures. We don't consider it at all, because I often find that we don't have anything coming out that, whenever there's conversation about health and wellbeing, the dental evidence, which is quite clear, does not get used. And it would actually inform
just saw in the HSJ down, not with old news, this is around the showing which parts of the system is joining up local authority and CCG commissioning in Manchester, so it's being meeting with, we know about this, but we didn't know, so that would be quite an opportunity to be able to actually, or maybe there was something going on there which would shove across together.
Quite a lot, yeah, of joining up. Okay, keeping an eye. Okay, what I'm going to do is I'm going to move on so that we hear about one of these lovely, wonderful local examples that we hear that are driving a lot of these work. From an example from James Rowland, who's the Strategic Commissioner in Brighton and Hove. James.
Thank you. I'm the Strategic Commissioner for Domestic and Sexual Violence and Violence Against Women and Girls, covering Brighton and Hove and East Sussex, and I head up the joint unit between those two local authorities. So that's just the background. And for the purposes of where I sit in terms of employment, I'm within Brighton and Hove City Council and particularly public health, although I'm in the community safety arena. But if anyone's aware of local government and community safety is often one of those lost departments which meanders its way around local government. So that's where I happen to be at the moment. What I'm going to talk about fairly quickly is just how we went about procuring a new domestic and sexual violence service and how we built social value into that, and that was something which came up in a local programme that's been alluded to. So in 2015 we undertook the procurement process, and it was bringing together domestic and sexual violence services for the first time, both within Brighton and Hove, but also between Brighton and Hove and East Sussex. So it was quite a lot of change for us in terms of how that was done. Because historically there'd been individual small grants to different providers, it wasn't joined up. It also meant for the first time we were bringing together a load of commissioners. So historically they were doing their own thing, or not doing it at all in some cases. And so Brighton and Hove, East Sussex County Council were the kind of primary local authority commissioners, and our police and crime commissioner as the second big part of that, as well as Kent, Surrey and Sussex Community Rehabilitation Company, so that the bit of the probation service dealing with treatment and lower risk offenders, and actually our clinical commissioning group in Brighton and Hove, and another commissioning group in East Sussex has just joined us as well. And the focus basically was making sure people got the right help at the right time in the way they needed, but we made the most use of resources because we were pretty certain we weren't making the best use of resources by having multiple different funding streams and providers. So the contract's about 1.2 million. Actually, it's just slightly above that at the moment because there are also some variation at any given time. The reason we were really interested in social value is because we knew that domestic and sexual violence services are best effectively provided by the specialist sector, the voluntary community sector, when we're talking about independent specialist expertise and input. There's a really established evidence base around that. It's often referred to as the coordinated community response. So what victims value is an independent advocate who can help them navigate the system. So they offer best practice interventions for that kind of work. But I suppose we were also thinking particularly about what social value they brought, and we'd never tried to assess that before with them, although they'd tried to get us to understand that previously in terms of things like social return on investment. And from a local authority's point of view, actually they also bring added value, and that's again something we wanted to put in there quite explicitly. So the way we went about it was trying to bring in our specialist DV services right from the beginning. So we had a very early consultation event saying this is the direction of travel, this is where we're going, what are the issues for you, what do you think our priority should be, what have we done well before, what we haven't done well, where are you at? And it helped them start to think about that stuff and get themselves hopefully ready. That was an initial consultation event, and then a kind of rolling series of conversations. Once we switched into the actual specification stage, where historically we've dropped out of conversations with any of our specialist providers, we recognised that was a problem, and then went to the national providers and said, look, we're going into procurement, we've got to dump our conversation with our local partners because they're going to be our bidders. Will you agree to be our critical friend during this stage of the process? So will you take over the reins in that regard? That was really helpful. They agreed. Of course, a lot of these are membership organisations. Their members are actually our local providers in that context. So we had to have some conversations with them about how they would do that. But it was really important in terms of getting the spec right. So from our point of view, the voluntary community sector was then engaged throughout the development of that specification from its very early genesis to its completion. We also scoped out what our voluntary sector said were the problems and what we felt other commissioners had made mistakes about when it came to commissioning DVSD services. And broadly speaking, with a really specific DV and SV hat on, these were the 4 areas that came up. One was gender neutral, so a lot of specialist commissioners, specialist services for domestic and sexual violence are now commissioned as gender neutral. The view, certainly I hold, is that's not helpful. It doesn't help women, who account for the majority of victims of DVSV services. It also doesn't actually help men. So if you take what is a gender neutral, a gender specific service, say it will work with men, actually doesn't work with those men at all. So our experience, for example, in East Sussex was a service which said it was gender neutral and worked with men. Actually, it saw 3 men a year. So it doesn't help either your women, who are the majority of your client base, but also your men and other particular communities to go gender neutral. It doesn't work. So we wanted to think about that. We looked at the model, and one of the other issues in other areas was that there wasn't a real link to ACT standards, nationally accepted standards around domestic and sexual violence work, which meant that the providers they ended up with were doing fairly generic work, which was very hard to quantify in terms of impact and outcome. We wanted a single point of access. What we didn't want was multiple helplines, multiple access points, which is what we had at the time. But we also recognised the risk of that to our local providers would mean that they just couldn't then do that. So we had to think about how we dealt with that, and cost versus quality. So we were very aware that actually if we took what were a number of smaller contracts and stuck it into a 1.3 million pot, actually that could potentially put them at a disadvantage. So within the spec, we responded to those particular areas. So we, instead of being gender neutral, like a lot of commissioners for DV specialist services currently are, we actually went with a gender specific commission. So we said actually the majority of our victims are female. You need to respond to that. You need to recognise that a chunk of our victims will be male. You need to respond to that. But we don't mind you doing that in different ways. Tell us how you'll respond. We also need you to think about diversity within that context as well. So LGBT as an example. We also then set out the model, but linked that very clearly back to what we could find in terms of nationally defined standards, so the kind of accreditation framework behind that, and that exists and is really well established for the domestic and sexual violence sector. And we also said we're going to have a single contract, so we're not going to deal with multiple providers, but we are quite happy for a partnership, so again, you tell us how you'll respond. And then internally, we tend to go for a 70-30 split for quality and cost, and made the argument we wanted that 60-40, so that we upped that in terms of the emphasis on quality. So when we then went into the procurement process itself, what we wanted to do is actually ask them to demonstrate social value. And again, it's something that we hadn't really traditionally asked for. So we looked at some of the work our local CCG was doing around how it was talking about wider benefits. And we asked explicitly a track record related to DV and SV and social value. So what we didn't want was a generic provider coming and saying, yeah, we do social value, but not being able to be specific about what that meant. So we said we wanted it related to DV/SV or an equivalent crime type, so we didn't mind someone passporting that stuff over. And we simply looked for evidence of what and how they generated that before. And we also then very explicitly said, if you do that, we need to see your evidence about how you would actually work in local communities and who you would engage, particularly around protected characteristics. Again, reflecting that feedback that you get, proposals which sound lovely but don't really have any detail. So we wanted to see the detail and see their thought about our local communities, really. We also asked about demonstrating track record of added value and looked at actually being a bit more explicit with them about our relationship and saying, you know what, we know we're not going to put all the money into this. This is what we have. How will you work with us to identify additional value for that? And some of that reflected the stuff we know traditionally is the social value work. So, for example, the successful bidder at the moment has got a very large application out to the Women and Girls Fund, which is going to generate a huge amount of social value if it's successful, and it's just something we'd never be able to fund, and they really thought that through in terms of what they added, and it's helped us as a local authority think a bit more about what we provide as core business to the DVSV service and what they bring, which is the kind of bells and whistles and a lot of the kind of community engagement the penetration in depth in terms of the community around talking about things like violence and abuse. We then need to think about how we're going to actually evaluate that, and one of the things we wanted to think about was the specifics around quality around domestic and sexual violence services, and obviously that thing it concerns things like safeguarding, but then also asking some more generic questions around the wider service offer, and that really picked up specifically things like service user engagement, but also included some specific questions around social and added value. And we also did some stuff around costs, around their assumptions, because what we were concerned about was getting an unclear picture of what different providers were going to give us, depending on the scenario. We also actually asked service users to help us with social value. So we had 2 specific questions in the evaluation which we had designed to be used by service users and ourselves, and we engaged another small local voluntary organisation to do the service user voice bit. So they had a small service user group who looked at those returns and kind of did their bit in terms of saying, actually, this is what we think this means. And that group then sent a service user representative, so one of the community engagement workers who sat on our evaluation panel. The other thing we did in terms of the evaluation panel was actually have a specialist service on that directly. Not someone we knew would be involved, so it was a regional specialist DVSV service. And I've got to say that was probably the best decision we made of anyone on that evaluation panel. It was a very good evaluation panel because they sat there knowing a huge amount about DVSV, but being completely objective really in terms of whether or not our potential bidders were offering value. And that critical friend input was incredibly helpful. So that's kind of very quickly what we did. The next steps really was kind of thinking about, well, if we've done all that and thought about social value and built a relationship with our providers during this process, and as it happened, the outcome was that the 3 local providers who had always had independent contracts came together to form a consortium which has gone to win the contract. How do we sustain that work with them? So they now have an annual delivery plan which actually they're about to present for 16-17, and that's divided into 2 parts. One is their business as usual, so what will they just do to get clients through the door in effect, but also what are they going to do to change the system in the local area. And that's not just about change for them, but also how will they work with our statutory and voluntary sector partners. And critically, we wanted that latter bit because we want them to be clear about what they need us to do to help them to release that kind of change. And we've actually also invited them to sit on our commissioning group. So the legacy of that kind of ongoing conversation now means they're informing commissioning decisions. And more importantly, we're recognising that their added value is better used and utilised when it's linked to what we are commissioning as well. So it means we can have an actual conversation about who's bidding for what money and how we shape that. As an example of that, recently that service put in a bid to our police crime commissioner around older people. That wouldn't have met the commissioner's particular expectations around that bid, but because that was of interest, that commissioner, who's an associate commissioner in this work, came to me as the lead commissioner and said, actually, we'd like to explore this further. Let's have a conversation about how we develop specific work around older people and put some more money into that contract. So it's a really good example of then the provider identifying the problem and then us being able to work with them to fit the solution within the current commissioning framework. So that's that bit. And then we're just working on the outputs and outcomes at the moment. So a lot of the problem we've had historically is rubbish data, frankly. Our providers have not had the best data in the world. We've struggled to interrogate it. They now have a single case management system that can do that, allows us to do some national benchmarking as well, and compare and contrast a bit. And we're finalising the key performance indicators around that, and particularly they will include specific stuff around social and added value, which we're just kind of developing with them at the moment. So that's kind of how we got where we got to. We're coming to the end of the first 6 months of that contract at the end of March. There's another 2.5 years to go, and then possibly 2 years after that. And obviously the context is really difficult. We've got increasing demand and a fixed amount of money, really. So it's meaning we're already having some quite difficult conversations about how we respond to that. But it means we're doing that in a single place increasingly. So, for example, at our next commissioning group, instead of us making decisions about what we would deprioritise, we're actually sitting around the table with them and our other commissioners to say, well, where do we go? How does that change our delivery plan? so it feels a bit more cooperative. So that's it really. Those are my details if you did want to get in touch. That was quite quick. I don't know if that was within
That was
10 minutes.
We've got 10 minutes or 9 minutes, so
Wow.
does anybody have any questions for James about that? Yes.
How did you find negotiating KPIs around social value?
I will tell you when we finished.
That's still on
So
hold.
what we agreed is the first 6 months because of the contract, because a lot of that involved a fairly long mobilisation process and bringing on lots of the practical systems of bringing 3 services together. First 6 months, which end in March, were really about kind of bedding it in, and it's during this phase that we're just finalising what the KPIs look like.
I think people are moving towards that more because previously it's been difficult to put into new contracts because the party line is that it's an unknown quantity.
Yeah.
But actually, if you explore opportunities in the initial period and then agree I'd be interested to know how it goes.
Yeah, well, happy to share. So it just didn't seem useful inventing them when we didn't know what it looked like, and we also knew our demand was
And
changing.
in a completely different way. So.
So in progress as we speak.
Any comments, observations or thoughts? Yes, Amelia. If you could just say where you're from.
Patrick Murray, Newfoundland Capital. I just want to say that was really interesting. Thank you for that. I think there's a lot of charities out there that are finding the move to larger contracts, particularly small specialist organisations, they're really struggling with it. And that you've just outlined a way to commission in, I think, a really positive way, the engagement all the way through in the way you're quite imaginative about bringing some of the umbrella organisations to do that, which has got into the more restricted phase up. It's really positive. So thank you.
And when we first saw the presentation, you delivered the presentation with the provider.
Yeah.
So it's true.
And obviously the provider would rather we didn't commission at all. clearly they would, and there's that underlying tension. But yeah, and what was really interesting when we went to the nationals, they all fell over themselves to help. And what they said was, of course we recognise that there's an issue with us being membership organisations. This is how we'll manage that. And then they said it's really amazing how many commissioners don't come and have a conversation with us about what we could offer. So the general response was they were incredibly helpful and recognised the benefit.
Thank you. Yes. So
Sorry to come back to that.
no, it's
I think the problem we had is that our umbrella body for the VCS became a delivery body in order to survive, and therefore it's competition for its members. However, it is still the consultative body for the council, so it actually finds out about everything and influences tenders, which it then bids for.
Yes.
One of the reasons we took on the role is because we're social enterprise startup and development. We don't compete with anybody delivering contracts, so it's one of the reasons we took the role on, and we took the role on in the BVO ESF lottery as well, to actually support them to deliver on that bid. So I think it's very interesting. I would like to know the questions you asked them, or before they came to the table, or how you sort of.
The nationals.
Well, anybody that's got a membership organisation that also delivers, because I think that needs to be clearer.
Yeah. And I suppose if you just think about the DVSV sector, it's a lot easier. Really, most of the nationals don't do direct delivery in that way, or if they do, it's really specific kind of work. They wouldn't be doing services on the ground. So I guess we didn't face that challenge, but yeah, recognise it's a difficult one.
Thanks. Any other thoughts and comments about that? For example, I mean, you're quite right there that there's an example of a way of doing it.
Yeah, I'm interested to know what social value impact bidders came back with. You're able to say a bit more about that?
Well,
and how diverse
yeah.
they were?
I mean, it's interesting. So, of the 3 organisations, one has a really established record of doing stuff on social value, and particularly talked about social return on investments. We've done a lot of kind of historic work around that. Interestingly, the legacy of some of that was our own strategic aims around violence against women and girls and domestic violence, which that they fed that finding into our strategic development. We then produced our aims, and it kind of came back the other way. So it was this didn't come out of the blue. There's a fairly long established relationship with cooperation. And I suppose they also have gotten, as I said, they've just got a bid out in terms of the Women and Girls Fund, and that what they were very particularly strong at is saying these are the particular projects we will do, and this is how we would engage with the local community and the benefits we expect to see with that. So, for example, they have a really good model of developing service users within the communities, but also what they're calling connectors, so people to go out and talk about domestic violence within their community or sexual violence. So it was really powerful about how they could reach more people in terms of our primary client group, which was DV, but also think about what the added benefit for those people were in terms of accreditation, for example. So to give some specific cases where their victims, survivors were perhaps unemployed, didn't have experience of for a long time of employment or kind of that kind of commitment, where then actually being able to build up a portfolio in terms of future job applications, for example. So that was what was really helpful, the historic SORI stuff, and then the more particular examples of what they would do within the community.
Okay. So I hope that's been useful for people to sort of hear a little bit about that. I think one of the things with this, I mean, there's a sort of, a couple of key messages coming out here. It feels to me what really resonates or is quite pioneering is the Director of Public Health of Blackburn and Darwin, talking about not lowest cost but greatest impact, which I think, is quite forward thinking then, but, that would explain why you're working alongside them. And talking about some of the things that you have in the report as well, which I think is really worth having a look at. And it is one of those reports where you don't have to sit down and read the whole thing from the beginning, but pick out bits. It's got good headings and saying what works, what doesn't, what you should look out for. Jessica's picked out particular things around leadership and organisational development and that kind of thing. Notwithstanding, the issues that you talk about in Milton Keynes, and also the other issue you raised around, that you've raised here about health in general, the kind of issue around dental. But I think the other thing that you've talked about is letting people know the equity indicators are on the way.
Yeah.
That's something for people to look out for, and they can do that via Institute of Health Equity
Yeah, they're
website.
actually produced by Europe, we've been involved. They'll be on our website, I'm sure, yeah.
Okay,
Or you can contact me directly.
but I can feed that back to SEUK about how we share that too.
Yeah.
I think there's some things to connect to you at the Institute of Health Equity about some of these examples around the country. I think the most brilliant thing about this feels like when people have been generating this, trying out new things and different ways of working and looking how to get better at this, everyone has been really willing to share. And absolutely can ring up commissioners, and there's a commissioner network in Brighton and Hove, I know, but the way people have been sharing has been absolutely brilliant, and the way people in procurement and commissioning are literally taking calls from and all across the country and sharing has been absolutely brilliant. So don't feel afraid. When people put up their contact details, I don't think people really go to that slide that as much as they should. Use it because people can answer those questions people want to share, I think, if something's worked.
Well, we stole most of our spec and then just added.
Well, absolutely,
So,
absolutely. So
we
knowing where
churnished
good stuff is happening, the Social Value Hub is particularly good for that, and there are a lot of health examples on there, and there will be more because we're still generating those as well. So, yeah, thank you very much, everybody. I think what you've got now is another half an hour of refreshments. I wonder what that will be, something nice, and scooting around and meeting people and taking contact details before we go into the final session. So thanks ever so much for joining us. Thank you.
Thank you.